Good morning. And if you're just joining us, welcome to the Foundation for Women and Girls with Blood Disorders, Hemostatic Disorders Colloquium, Women and Girls with Hemophilia, Management of Delivery session. I'll be presenting. I'm Dr. Andra James. I am Professor of Obstetrics and Gynecology in the Division of Maternal Fetal Medicine and Consulting Professor of Medicine in the Division of Hematology at Duke University. I have no conflicts of interest to disclose. Our agenda for this session is maternal risks of bleeding at delivery, fetal and neonatal risks of bleeding at delivery, preconception and prenatal preparation for delivery, management of delivery to reduce the risk of maternal bleeding, management of delivery to reduce the risk of fetal and neonatal bleeding, and postpartum management. I'll start with maternal risks of bleeding at delivery. In hemophilia carriers, maternal risks of bleeding at delivery are likely related to factor levels. In pregnancy in general, there are changes in coagulation factors. Factor 8 increases, factor 9 does not seem to increase significantly. In hemophilia B carriers, factor 9 levels likely do not increase significantly. In hemophilia A carriers, factor 8 levels likely do not increase to the levels achieved in other women, but other factors increase. Nonetheless, hemophilia carriers are likely at a higher risk of bleeding at the time of delivery than other women. I should just touch on the mechanisms of postpartum hemorrhage in general, and I categorize them as obstetrical or uterine, surgical, or systemic. And when I refer to obstetrical bleeding, I mean abnormal bleeding originating from the tiny vessels within the pregnant or postpartum uterus, caused by failure of the uterus to contract, a process we call uterine atony. And uterine atony accounts for more than 80% of postpartum hemorrhage. When I refer to surgical bleeding, I'm referring to bleeding due to incisions, laceration, ruptured vessels, or a ruptured viscus, including bleeding from birth trauma or incisions with cesarean delivery. And that accounts for most of the rest of postpartum hemorrhage. And then systemic bleeding, I will use that term to describe bleeding due to inadequate hemostasis, which could be due to thrombocytopenia, platelet dysfunction, low levels of clotting factors, abnormal vasculature, metabolic dysfunction, or hyperfibrinolysis, which may evolve acutely as in DIC or may evolve chronically in an acquired or inherited condition, like hemophilia. Well, what is the incidence of postpartum hemorrhage in all women? Well, 3% of women experience primary or immediate postpartum hemorrhage, meaning postpartum hemorrhage within the first 24 hours after delivery. And 1% or less experience secondary or delayed postpartum hemorrhage, meaning hemorrhage occurring after the first 24 hours after delivery. There are no large studies of postpartum hemorrhage in hemophilia carriers, but we have a number of case series or cohorts. And in those case series or cohorts, there was an increased rate of primary postpartum hemorrhage, as well as an increased rate of secondary hemorrhage. And remember, this occurs in the general population at a rate of about 3%, with a rate of 1% or less with secondary postpartum hemorrhage. So hemophilia carriers do appear to be at an increased risk of postpartum hemorrhage. Now I'll talk about the fetal and neonatal risks of bleeding at delivery. Fetuses and neonates with hemophilia are at an increased risk of bleeding at the time of delivery. Now, what fetuses and neonates are at risk? Well, this is a slide that shows the genetic status of mothers of affected males. And 65% of affected males have mothers with a positive family history of hemophilia. And another 23% turn out to be carriers by genetic testing or birth of another affected male. So that comprises 88% of affected males have a mother who is a carrier. And what is the inheritance of hemophilia? Well, this is well known to you. Hemophilia is an X-linked disease. In a woman who is a hemophilia carrier, 50% of her sons have a chance of having hemophilia, and 50% of her daughters have a chance of being hemophilia carriers. And when does this first present? When does hemophilia first present? Well, 35% of affected males have their first bleeding episode within the first 30 days of life. And this slide depicts where the sites of initial bleeding in infants are, and half of the time it's with circumcision, and almost a quarter of the time it is due to head bleeding, which has considerably more implications, and half of the cases of head bleeding are intracranial. Now, the risk of intracranial hemorrhage, as it turns out, depends on the mode of delivery. From this systematic review from Davies and Kadir, published in Hemophilia in 2016, which relied a great deal on the work of the Centers for Disease Control here in the United States, 3.1% of affected males born through the vagina had intracranial hemorrhage, as opposed to 0.4% who were born by cesarean. So in affected male infants, the odds of intracranial hemorrhage with vaginal delivery are 9-fold. Now, this next slide is about the risk of intracranial hemorrhage in any fetus or neonate. This is not specific to males with hemophilia. This is the risk of intracranial hemorrhage in any fetus or neonate. And I present this data because it provides some perspective on the risks conferred by various modes of delivery. And it's a large study. And using spontaneous vaginal delivery as the reference value, vacuum delivery conferred a risk of 2.2-fold, forceps delivery 2.9-fold, and cesarean delivery after labor 2.0-fold, and cesarean before delivery 0.7-fold, seeming to be protective, but not statistically significant. And it may be counterintuitive that cesarean delivery after labor is not protective. But keep in mind that one of the most common reasons for cesarean delivery is a failed vaginal delivery. A difficult labor can wind up in a cesarean delivery, suggesting a fetus is already exposed or injured. These are some comparable data on the risk of intracranial hemorrhage in fetuses or neonates with hemophilia. And again, using spontaneous vaginal delivery as the reference value, operative vaginal delivery, meaning forceps or vacuum delivery, conferred a 4.4-fold increased risk, and cesarean delivery was protective with a reduced relative risk, reduced by about 2/3, with a relative risk of 0.34. And in this case, they didn't separate before labor or after labor, and cesarean before labor may have, if we were able to see those data separately, might have conferred an even greater benefit. Now I'll go on to talking about preconception and prenatal preparation for delivery. The principles are to identify the fetus at risk and assemble the team. Well, who are the obligate or possible carriers? And I think they are well known to this audience, especially after Dr. O'Brien's talk, but in the community, not so well known. Obstetrician gynecologists and other people who have direct contact with potential patients should recognize that an obligate carrier is the mother of a son with hemophilia if there is another affected male relative, or the mother of more than one son with hemophilia. Like the woman I saw this week who had 3 affected sons. Or the daughter of a man with hemophilia. And possible carriers include the mother of a son with hemophilia, but no other family history of a bleeding disorder, or the sister of a male with hemophilia, or the daughter of a female carrier, or another relation of a male with hemophilia. We had a patient in the neighboring community who told her obstetrician gynecologist that her maternal uncle had hemophilia, and that wasn't investigated, and her male infant suffered unnecessary bleeding in the newborn period related to the fact that a diagnosis wasn't made in a timely way. So those are the obligate and possible carriers based on history. But now we have genotyping. And what are the advantages of genotyping? Well, we can confirm the diagnosis and possible carriers. We can provide potentially beneficial information for obligate carriers. We can provide information for pre-implantation genetic testing of embryos, or we can provide information for prenatal diagnosis of a potentially affected male fetus. And how do we proceed with identifying the fetus at risk? Well, if a woman has had genetic testing and has been genotyped, she can have pre-implantation genetic testing of embryos. She can have besides pre-implantation genetic testing, she can have prenatal genetic testing by chorionic villus sampling or amniocentesis. She can have prenatal genetic testing in the 3rd trimester for delivery planning purposes. We can also stratify the testing based on the sex of the fetus. We can use now cell-free fetal DNA testing in the 1st trimester to determine whether a fetus is male or female. And of course, we have ultrasound imaging in the 2nd trimester. And then we need to assemble the team, which includes a genetic counselor or other knowledgeable individual who can talk to the woman with hemophilia about the potential of having an affected male infant. We can use the adult hematologist to manage the patient's bleeding risk, the obstetrician, the obstetric anesthesiologist, the neonatologist for the immediate care of the newborn, the pediatric hematologist as a consultant, and all the outpatient and inpatient nurses. How about the management of delivery to reduce the risk of maternal bleeding? Well, with respect to managing the maternal risk, we will want to assess maternal factor levels and use hemostatic agents as necessary. all women, whether they have an underlying bleeding disorder or not, are at risk of postpartum hemorrhage. So we would employ all the routine obstetric measures to prevent and treat postpartum hemorrhage. We would want to see factor levels of at least 50% in our women with hemophilia, and employ factor replacement in women with levels less than 50%. Factor replacement should be with virally inactivated plasma-derived or recombinant concentrates rather than cryoprecipitate or plasma. The threshold for treatment, choice of product, dosing, and duration of therapy are based on observational studies or expert opinion. There is some guidance provided by the World Federation of Hemophilia. And tranexamic acid can be used as an adjunct. What about delivery of the fetus to reduce the risk of bleeding? In the fetus with known or possible hemophilia, my recommendation is to perform a cesarean delivery prior to labor and avoid or postpone invasive procedures. Now, why would we subject the mother to a cesarean delivery to protect the fetus? Well, we do cesarean delivery to protect the fetus in actually less risky situations for the fetus, like breech presentation, which confers a threefold increased risk of fetal hazard. A previous cesarean delivery where we have no compunction about performing a cesarean delivery, which because cesarean delivery provides protection to a woman who's had a previous cesarean delivery, and a vaginal delivery increases the risk threefold. And hemophilia, in other words, delivery of an affected infant, increases the risk of birth injury ninefold. And just, what happens during vaginal delivery that's just so risky? Well, this slide comes from an article on labor that was published in the New England Journal. And it conveys fetal head, maternal pelvis relationships for 3 different primates. At the top, we have the size of the fetal head and the size of the maternal pelvis in the chimpanzee. And you can see there's a lot of room for the fetal head to get through. In the middle frame, you see the fetal head of Australopithecus coming through the maternal Australopithecus pelvis, and there is some room. And in the third frame, you see the human head coming through the human pelvis, and there is barely any room at all. These are data for asymptomatic intracranial hemorrhage in 88 healthy newborns who were studied by magnetic resonance imaging after birth. These are not infants with hemophilia. These are healthy newborns. But it, again, conveys some information about the risk posed by mode of delivery. So in this study, where they looked at 88 healthy newborns with MRI after delivery, they saw that 25% of babies born by vaginal delivery, spontaneous vaginal delivery, had asymptomatic intracranial hemorrhage. 31% who were delivered by assisted vaginal delivery, what we also call operative vaginal delivery, i.e. forceps or vacuum delivery, had asymptomatic intracranial hemorrhage, and none of the babies born by cesarean delivery had asymptomatic intracranial hemorrhage. And these are data in 813 newborns with hemophilia. And this is the rate of intracranial hemorrhage by mode of delivery in 813 newborns with hemophilia. So 2.5% of those who had a planned vaginal delivery had an intracranial hemorrhage. The rate was broken down by type of delivery. That rate was 1.5% in those who had a spontaneous vaginal delivery, 10% in those who had an assisted vaginal delivery, i.e. forceps or vacuum, and 2.5% who had a cesarean after labor, and 1.6% who had a cesarean before labor. And what I found particularly disturbing was that 18 of the assisted vaginal deliveries occurred when a family history was known, which was 4% of the 466 deliveries of obligate or possible carriers. So these doctors knew that they had a potentially or affected male infant to deliver. They knew that they should not deliver these babies by forceps or vacuum, yet 4% were delivered by forceps or vacuum. So what is the big fear with just proceeding to a cesarean delivery? Well, the fear is putting the mother at risk of bleeding. Now, these are two large randomized trials in unaffected women, but it gives some idea of the risk conferred by cesarean delivery. And why would women ever consent to being randomized to cesarean versus vaginal delivery? Well, in the first case, it was women carrying a breech birth, and they were willing to be randomized. And in the second case of the second trial, it was women carrying twins. And you can see that in the breech trial, the rate of cesarean delivery, or excuse me, the rate of blood loss greater than 1,500 milliliters was 0.2% in the planned cesarean group versus 0.4% in the planned vaginal group. And the rate of blood transfusion was 0.4% in the planned cesarean group and 0.8% in the planned vaginal group. And there was no statistically significant difference between those who had a planned cesarean versus a planned vaginal group. And then we have very similar findings in the twin trial, this large trial of randomized trial of twin deliveries, where we had a blood loss of greater than 1,500 milliliters in 1.9% of those with planned cesarean versus 2.3% of those with planned vaginal delivery, and a rate of blood transfusion of 4.7% in those with planned cesarean versus 5.4% in those with planned vaginal delivery. So you can see that there was no statistically significant difference between those with planned vaginal delivery versus planned cesarean delivery, and that may be counterintuitive because we know that a cesarean delivery is associated with increased blood loss. So why was there no difference in these two large randomized trials? Well, this was planned vaginal delivery versus planned cesarean, and a planned vaginal delivery includes failed vaginal delivery. It includes operative vaginal delivery and an unplanned cesarean delivery. And an unplanned cesarean delivery carries a greater risk of blood loss than a planned cesarean delivery. So when we compare the two groups, planned cesarean versus planned vaginal, the unplanned complications of the planned vaginal group cancel out the potential benefits so that the risks of bleeding and blood loss with planned cesarean are comparable to those with planned vaginal. So as I've already alluded to, one of the principles is to avoid vaginal delivery. Well, why not just let the woman labor and then just avoid vacuum-assisted birth or forceps-assisted birth if that appears to become necessary in labor? Well, the only way to avoid an operative vaginal delivery, forceps or vacuum, is to plan for a cesarean delivery before labor. There is a point of no return in the pelvis where the baby's head is actually too low to perform a cesarean delivery, and the only way to get the baby out safely if there is fetal distress is to perform forceps or vacuum delivery. So other invasive procedures should be avoided in labor if a vaginal delivery is planned, like fetal scalp electrodes. And at the time of delivery, umbilical cord blood, which is the fetus's blood, should be obtained for factor level testing and PTT. So this is a summary of delivery recommendations for the affected male fetus or the possibly affected male fetus in the mother who has a factor level of greater than 50% in the third trimester. The mother should still plan to deliver at a hemostasis center with a multidisciplinary team for the benefit of the fetus. For the female fetus or unaffected male fetus, she can deliver in her community hospital with routine care. For the mother with factor levels less than 50% in the third trimester, again, she should be at a hemostasis center with a multidisciplinary team for her care and the fetus's care. And the same is true if she's carrying a female fetus or unaffected male fetus, she needs to be in a hemostasis center with a multidisciplinary team for her own well-being. After delivery, during the postpartum period, factor replacement is recommended for women with factor levels less than 50%. Non-steroidal anti-inflammatory drugs should be avoided. Tranexamic acid can be used as an adjunct. And desmopressin in factor VIII deficient women can be used after the immediate postpartum period. In the immediate postpartum period, it is too difficult to restrict fluids, and there is some cross-reactivity with oxytocin. This is normal factor VIII levels in unaffected women. Factor VIII levels in affected women are probably lower, but probably follow a similar trajectory, probably are back to baseline levels around 2 to 3 weeks postpartum. And we should anticipate that. So in summary, overall, in hemophilia carriers, maternal risks of bleeding at delivery are likely related to factor levels. Fetuses and neonates with hemophilia are at risk of bleeding at the time of delivery. Preconception and prenatal preparation for delivery involves identifying the fetus at risk and assembling the team. Reducing the risk of maternal bleeding requires assessment of maternal factor levels and possible use of hemostatic agents. Reducing the risk of fetal neonatal bleeding requires performing cesarean delivery prior to labor and avoiding invasive procedures for affected or potentially affected fetuses. And postpartum management involves avoidance of NSAIDs and possible use of hemostatic agents. I'd like to thank you for joining us. I'd like to thank HTRS for making this program possible within their larger program. And I'd like to acknowledge my colleagues, particularly Kristen Nunez, our genetic counselor, and all of my colleagues at the Duke Hemostasis and Thrombosis Center. Thank you very, very much.